I've never met Dr. Crystal Beal in person, but I'm hoping to have the opportunity. I always enjoy our conversations and learn so much. Dr. Crystal Beal, a board-certified family physician, started Queer Doc with the mission to raise the bar in gender-affirming care and improve LGBTQ lives through telemedicine-based direct clinical services, provider education, and LGBTQ DEI healthcare consulting. They leverage their lived experience and medical expertise to offer a level of unsurpassed nuance to their services. We talk about gender-affirming medical care and the evolving language surrounding it, and how to best recover after making a mistake regarding that language. Words matter. Dr. Beal attended Florida State University College of Medicine, where they helped found the LGBTQ medical student group. They completed their training at Valley Family Medicine Residency Training Program. Dr. Beal sought extensive additional training in sexual health, queer health, and gender-affirming care, including self-study, continuing medical education trainings, and shadowing experts in the community. They have focused CME in the topics of cultural humility, trauma-informed care, sex-positive care, and kink-affirming care. They share their knowledge working with medical students and through their online program, queercme.com. Our audience, Physician's Guide to Doctoring, listeners can get 10% off with the code PGTD 2022. They are a non-binary femme and are super queer themselves, enjoying queer burlesque, vintage fashion, and their queer kinky poly family.
Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. Those on this podcast accept no liability for the outcomes of medical decisions based on this information. As the radiologists like to say, clinical correlation is required. This is not medical advice, and this does not constitute a physician-patient relationship. If you have a medical problem, seek medical attention. And now, here's Dr. Bradley Block.
Dr. Crystal Beal, thanks so much for coming back on the podcast. You've always got such great ideas for episodes, and I always learn so much from you and enjoy talking to you. So thanks so much.
Yeah, I'm super excited to be back, Brad. I really appreciate your platform that you share for me to get on my soapbox. I love it.
Well, thank you so much. So today we're gonna talk about the main topic is the evolving language of gender-affirming medical care. But I think as more of an intro to that is just what is gender-affirming medical. Actually, let's start with what isn't gender-affirming medical care. Let's start with the negative. Like, what are some things that people would think of as being, but you're like, no, actually, that's not quite it.
Actually, I think that's a great way to frame the question. One, I'm gonna just give the context that every person you ask will have a different answer to this question, which is also true when you ask someone, what is gender? Right. And that's totally fine. We all get to have individual definitions. I'm just going to give you my opinion, which, similar to assholes, everyone has one. Some have more value than others. But I do actually think it's easier to...
I've never heard it said that way before, but love it. Love it. Okay. Sorry. Go ahead.
That's all right. I think it's just it is actually easier to think about what it isn't, because I think really, I don't think any aspect of healthcare isn't gender-affirming care. Really, I think gender-affirming care is similar to trauma-informed care and standard precautions, and the fact that it should be universally applied in healthcare. And so it can be as simple as back to our first episode, using someone's chosen name and chosen pronouns. And I think currently in this super politicized environment, right, I think sometimes physicians and healthcare providers think that they have the inherent right to decide whether or not they're going to honor someone's chosen name or pronouns based on their personal values and their political beliefs. And that's actually inaccurate, right? Because we all know we took an oath. I think most of us took an oath, right? About doing no harm. And really the data and research shows that consistent use of someone's names and pronouns is going to decrease their depressive episodes by 71% and their suicidal attempts by 65%. And so by actively ignoring someone's name and pronouns as a healthcare provider, you're increasing their risk of suicide, which is an antithetical to the oath we all took. And so I think gender affirming care is every part of healthcare. even if you're not the person prescribing the testosterone, or you're not the person prescribing the estrogen or the puberty blockers, there are components of it that need to be included at every level, at every stage, with every specialty, with every provider, with every healthcare worker. Does that answer the question, or just like make more questions?
I think so. I think so. Although maybe that would be like inclusive care.
Mm-hmm.
Maybe I'm not using that word correctly. Maybe I am. I don't know. And whereas like gender affirming care, like you provide gender affirming care, right?
Yeah.
I think as an otolaryngologist, I might inclusive, and I think in some ways the term like holistic has been co-opted by all the, Gwyneth Paltrow goop woo out there. But I think as you can be a holistic provider that, does things like that. Although I have to say that's like using someone's pronouns it's like the bare minimum, right? Like that's the least that you should be doing when you're taking care of a patient, of any patient.
Agreed. I think like the bar is actually really, really low. And like we could debate terminology probably like until your baby wakes up at 5:30 in the morning. Right? Because it is like, what is inclusive, what is affirming? And, in my mind, gender affirming care is anything that's going to improve a health outcome. And so like, if we can measure like suicide attempts, like related to pronoun use and related to like inclusive paperwork at a healthcare system, that does actually seem to be like affirming to me because it's changing a healthcare outcome. But I think inclusive is a great word as well. And it's like, as you said, is a bare minimum goal that we should all have in our practice, and not just around gender, right? Around all of our like differences as humans. So
exactly. But so when I take out someone's tonsils, that is not gender affirming care, right? That is, it's not. So, but you do provide gender affirming care in your practice. And so what is that?
Yeah. And so if you want to kind of divide it out like that, right?
Like
then you're
medical
really
care. Yeah,
you're really talking about a medical intervention that affirms someone's gender as opposed to like a clinical action that you're taking. And that is like a way a lot of people will define it out. And that's a great like definition to think about. And so then you're talking about the actual prescriptive practices of a provider with things like testosterone or estrogen or anti-androgens or, puberty blockers. Sometimes it's just contraception. Sometimes it's just stopping someone's like menstrual cycles. There are lots of kind of things that we do that sometimes maybe people don't realize are gender affirming care, but are.
Okay. So far what you've mentioned is all hormone therapy related. Those are the examples that you've given. Is there anything involved in gender affirming care that is not like prescriptive or that would involve something other than hormone?
Yeah, I think, if you're getting, again, technically framing it in the context of medical interventions, there's lots of procedures. You can use Botox to affirm someone's gender. Like we use it to like decrease master muscle size to like change the shape of someone's jawline. You can use fillers to like create like a softer, rounder, fuller face. And then, there's obviously surgical interventions in the context of like gender affirming mastectomies for top surgery, and there's bottom surgeries. There's also like a lot of other surgeries a lot of people haven't heard of in the context of like body contouring. Kind of hip to waist ratios is a way that our society codes gender like really quickly when we look at someone. And it's something that isn't typically affected a ton by hormonal prescribing if someone's already completed puberty. And so body contouring is a procedure that can affect that a little bit more. So there's kind of those interventions. There's also going to be like mental health services and counseling support that's going to provide affirming interventions as well. And then like maybe taking someone's tonsils out isn't affirming to you and it's going to be inclusive. And there are like lots of like kind of
I think there might be voice-related surgery, right? Like
there are voice-related surgeries.
Yeah.
There's also a lot of like co-occurring like health conditions that we see like in higher rates among gender diverse people, like disordered eating and autism spectrum disorder. And so like having interventionists in those areas that are also like well-versed in working with trans and gender diverse clients are actually really hard to find, particularly in the disordered eating community. Like, I mean, have any kind of marginalization and it's hard to find care for someone in that community because it's for so long centered upper middle class, like thin, white, privileged, cis women. And so like, and we know that that's just a small part of disordered eating. But unfortunately, that's where all of the like research and care has gone. So that's like a really complex issue that really lacks a lot of what we need for our gender diverse clients. And so it is in many, many areas of care.
So one of the things that you wanted to focus on, the main focus for today was language, right?
Yeah.
Language in gender affirming medical care. So what's the historical language been?
Yeah, I think, and it's interesting because like we're medical providers, right? And I think prior to the advent of electronic medical records, our documentation was really to communicate with each other and with ourselves about what someone's health conditions and needs were, and like what our thinking processes were, and what our interventions were, and what we were hoping to get from those interventions, right, in our follow-up plans. And if you look at like gender affirming care, it's like so enmeshed with this like societal construct of gender that like it hasn't been teased apart into like a truly like medical discipline in a way that like is well communicated across chart notes, right? And so like I will get chart notes from people, and they'll say like, patient percent seeking feminizing hormone therapy, goals for care, feminization, estrogen and spironolactone started. And I'm like, I don't know what the fuck that patient wanted out of their care, right? Because feminine means something very different to me than it means to you, than it means to that patient, than it means to someone, in Australia, than it means to someone in Greece, than it means to someone in Italy, than it means to someone in New Orleans. Like we all have like a societal and cultural construct around these concepts of masculine and feminine that like are going to be highly affected by like the culture we grew up in, the region we grew up in, and then our own individual like goals and values, not to mention like the overarching like standards of beauty that exists within our culture. And so like, what the fuck does like goals of care feminization mean? Does it mean that that patient wanted like a curvier body, like more breast development? Does it mean that that patient wanted softer skin? Does it mean that that patient wanted different body odor? Does that mean that patient like, wanted to stop erections or keep them? Like there's so many like specific goals for care that like aren't communicated by that statement in a way that as a like provider getting a transfer of care, I can actually like use, right? I think that's like the part that for me is so fascinating to think about, like how, so typically like we would stray away from terminology that doesn't actually like concisely and clearly communicate what we need to know medically, but in the realm of gender care, we just rely on it like hand and foot and don't even think about it. And so for me, when I'm writing, like when I'm thinking about my chart notes, I'm thinking, okay, if this patient transfers care, what does the other provider need to know? They need to know that this patient, came to me. They need to know like what organs they were born with and like what hormonal milieu they kind of had exposure to over what period of time, and then what organs they have now for preventative care and primary care, like screening purposes, right? And then what hormonal milieu they're like being exposed to and for how long, and then like what their goals for care are. And so like I'm always trying to think of like, how am I going to communicate that in a concise fashion, but that still includes everything that's medically appropriate, and really just pulls out this like social construct of gender, because it's not actually relevant to the work I do as a physician, right? It's super important to my patient and to our society and to all of us as like individuals, but like what I'm medically doing is I'm prescribing a hormone to change something in your physical or emotional experience, and I need to know what like things I'm actually targeting, because it will change like how I prescribe. And so that's like my big push in like this context, like for us to like really try to desocialize our brains from that gender construct.
Well, I think this translates really into all medical care, the way that you're saying it, right? Because there is like cancer care, right? Like what are the patient's goals of care? Like I feel like like palliative care, especially, Like where it can be so where our values might not be the same as the patient's values. And actually, this is something that I sometimes say to my patients. They're like, "What would you do if it was your kid?" I'm like, I can't. I can tell you what I would do if it were my kid, but it's not my kid. My values are not the same as your values. I can't make this decision for you. I can educate you as best I can about the scenario, but I can't force my I don't want to force my values on you, because also if you had gone into the exam room with a different otolaryngologist, you might have gotten a different recommendation. And so we have to recognize that and, just help guide you as best we can without putting our values on you. Right? It sounds very
Completely agree.
similar.
Yeah.
What you're doing in gender affirming care is what like the rest of us should be doing in all medical care.
Yeah, I completely agree. And like patient-centered, like value-driven care, right, is a huge focus. I think in the shift in medicine, right? Like away from kind of like historically we had a fairly like paternalistic approach, right? And I think the move has been away from that over the past several decades, which is to really center someone's values. And I think again, like in gender affirming care historically, like really we have used the terminology feminizing and masculinizing. And the other problem with that terminology, besides like not communicating what medical providers actually need to know, is like also it like falsely assumes a binary of gender and like excludes like a whole component of people who don't connect or identify with that terminology. And so like you run the risk of like really misgendering and causing significant trauma and harm to patients that aren't connected to that terminology by trying to shorthand your way into language that you think is understood. And so I think that's like kind of the other thing to think about, when we're documenting and charting.
So with regards to the language specifically, what you're saying is the broad terminology of masculinization or feminization is really not specific enough, not nearly specific enough for many reasons. But is there any other language that has been used historically that has become passé?
Yeah, lots. Like,
I don't
right.
know if passé is
Yeah.
aggressive enough to say, you know what I
Right,
mean?
right.
You know
There's
what I mean?
definitely like, I mean, right, there was a history of gender identity disorder being diagnosed as a mental illness, just like that used to occur with homosexuality, right? And so like it's gone through like the terminology of like transvestism, transsexualism, like terms which can be very offensive to some people and other people claim as identities and are very proud and comfortable with, right? Um, but in general terminology, like we tend to recommend avoiding. I think also it's not uncommon historically to see transgender used as a noun. That is not something we do in current terminology. Like we use it as an adjective. I think another thing that I see frequently in like, gosh, we're gonna like talk about language for a very long time. In language though is an assumption of a cis normativity, right? Which so basically what that means is like, right, people think that cisgendered is like the normalness of like life in the world and like transgenderness is like an abnormalness. And ways that that is represented is like when someone says this patient is a woman and they don't put cis in front of that. It's like they're making the assumption that if we're using woman, it's obviously a cis woman. And then they make the distinction that a trans woman is a trans woman. And that's like a completely inappropriate use of the terminology because it's like marginalizing and like othering transness in a way that's just not appropriate. Like if we look at across history and across cultures, like we see, genders that are diverse and outside of a binary through like most cultures historically over many, many years. It was like really the advent of like colonialism that really kind of tamped down like the wide breadth and birth of gender that used to exist within most of our cultures.
Yeah, it
So
sounds like if you were to take a history or tell your attending history, this is a 27-year-old black female. But then if it was a white patient, just say, well, this is a 27-year-old female, and just
yeah,
well, I didn't say they're if they were white, because the assumption is that, right, because that is currently the majority in this country. But it's what you're saying is it's just because it's the majority doesn't mean we should assume, because then that
Yeah.
makes it seem normal versus abnormal.
Right. Right. And so definitely like that comment, like, right. A lot of times, like, I'll actually say, instead of saying like 27-year-old, Black cis female, I'll say this is a 27-year-old, person, but I'll typically just say person instead of male or female. Cause like, again, gender doesn't necessarily need to be prioritized in like my concept of like medical care. And so I'm going to say like, it's a person. And then I'm going to say like, presenting, seeking gender affirming bilateral mastectomy, currently on testosterone therapy, which was started 5 years ago, has not had any other gender affirming procedures or surgeries. Like organs for preventative care screening purposes include like a cervix, uterus, and ovaries, and breast tissue, right, or chest tissue. And so like that's like how like my brain kind of organizes things and thinks about it more. What am I actually trying to communicate when I'm trying to communicate gender? And I'm trying to communicate like a potential like correlation or association with certain specific disease states, right? Like we see certain disease states more commonly with certain hormonal states, right? So like autoimmune conditions are more common in bodies with more estrogen frequently, right? Similar to like certain types of cancer, right? You're more likely to see estrogen-fed cancers in bodies that have more estrogen exposure. That doesn't necessarily mean that's a body that was assigned female at birth, right? Or presumed female at birth, right? It just means it's a body that's had estrogen exposure for long enough that breast cancer started to become a concern. And so I'm always trying to pull it apart and think about like, what am I trying to communicate to other providers and what do I need to know to take care of this patient?
Right. That's the purpose of medical, like that's the purpose of documentation. It's communicating with yourself, communicating with another provider, billing and liability.
Right.
Those are the reasons.
And the really great thing is like when you pull that terminology like feminine and masculine out of it, you also pull like the chance of, again, misgendering someone who doesn't associate with those terms out of your documentation. And like it's really, really common for patients to have access to their chart notes these days, and so
and
like
get their lab results before you do.
Right. Yeah. So like think about like how harmful that would be for a patient who like felt like they had a like therapeutic relationship with you and really felt seen and like understood by you. And then like they're like in black and white is you, inappropriately gendering them and causing them, for some patients, it's going to be like, they're going to move on past it and it's not going to be a big issue for them. But for other patients, like it might delay them seeking care. It might, prevent them from getting like services that they need. And it can be like very traumatic.
Oh yeah. It could like, right. I thought I had a relationship with this doctor. I thought I finally found a doctor that got me, but again, it's happened again. It's the entire medical establishment. And then we've alienated them. We've lost them.
Yeah.
Yeah.
Yeah. So I think like, it's just like a nice, like you're communicating what you need to know. You're avoiding like the risk of like causing harm and trauma. And I think, typically in my notes and documentation as well, like in my assessment and plan for their gender care, I usually keep a section of like desired terminology from so, typically we'll ask patients like, is this their terminology you want us to use specifically around your gender, your body, or any of your body parts, right? And so we keep that list like, just like it carries over, and that if most people have Epic, it just carries over with the like
carryover comments. Yeah.
Diagnosis. Yeah. And so it stays there and it helps keep like everyone on the team on track. And then it's something I can refer back to before I see the patient. So like I'm on the right page as well.
So how do we recover from a mistake? Right? Like for an example, earlier when you said that it shouldn't be assumed that the patient is cis. And then when I gave an example, I actually left out, I did not say trans or cis. I just, so I made a mistake. I apologize. So but we're interacting with the patient. How do we recover?
Yeah. I think a lot of advice in like organizations will say like apologize and move on, like don't belabor the point. I think a lot of times in our society though, when we apologize, it kind of puts the onus and like burden onto the other person to like say like, oh, no worries, or it's okay, or it's fine. When a lot of times it might not be for them. So I think it's actually a better practice to just say like, oh, I heard that you actually go by, X, Y, or Z, or, oh, I just used the wrong pronouns for you. I'm going to work on that. How is your cough doing today? Like, it's like just calling it out, acknowledging that it happened, like making a commitment to work on it and then moving on, I think is really the best thing we can do as providers. Because it doesn't ask our patients to like try to caretake us when we've made the mistake. Right. And it doesn't like make it about us by like belaboring the like, I'm so horrible and I fucked up and blah, blah, blah. Right. And so it just like allows the attention to stay on the patient and their needs and our commitment to those needs.
Love it. Anything else that you think that we didn't discuss today, either about gender affirming language, gender affirming medical care, that we need to cover?
I'm
No,
sure
is a
there's like
perfectly
so many
fine answer.
I'm sure there's so many things, and it's the end of the day for both of us. But I'm happy to like plug my education series if that's an opportunity we can do.
Yeah, do it. Do it.
Sweet.
Do it. Let's hear it.
Sweet. So if anyone is more interested in learning about gender affirming medical care, I have an online platform called queercme.com. And there is actually a whole course that has 14 hours of CME, CE certified webinars. It has all of like my chart note templates for the care I provide. It has all of the letter templates if you're trying to refer someone for surgery or help them with legal transition, or write a letter of medical necessity. And then we do quarterly Ask the Expert events that are live streamed. So you can talk to experts in the field about any questions you have. And then there's an active community as well where you can post questions, thoughts, or ideas and have other people respond. And so all of that's online. And I think kind of the difference between doing that through a conference like WPATH or doing something like more traditionally done is like it's online, it's at your own pace in your own home. And I have lived experience as a gender diverse person. Like I identify as femme, but in like a non-binary fashion. So it's not part of like the traditional female or womanhood in any way. And I have multiple partners in my life and family members who have gone through medical transition as well. And layered with like a high volume practice in gender affirming care, I think it just brings kind of a level of nuance to what I share in the platform that's a little different than you get at a conference. In addition to the fact that I think a lot of conferences really focus on the guidelines like WPATH and UCSF and Endocrine Society, and they're all a little bit outdated at this point. Like the standard that those of us who do this work a lot practice at is a fair bit different than what is readable in the current guidelines. WPATH is coming out with their SCO 8 this year, so there is going to be a big update to the guidelines, which is exciting to see.
And then your website.
Yes.
Queerdoc.com.
Yeah.
Which I love. I love that website.
Thank you. Lots of educational information for patients there. Lots of resources if you have any gender diverse patients that need support groups or education on hormones or how to do their own injections or anything like that. Lots of information there. And we also have our provider education link through there, as well as our corporate consulting. So if your organization is like sucking it up with the names and pronouns, we can definitely help you out there.
Wow, you are all over the place. You're wearing a lot of hats now. You're really growing the business. I love it.
Yes. I think with the changes in like regulation for prescribing around COVID, we saw so many clinics come into the telehealth space. And that's amazing. I love that trans and gender diverse patients have more options. But we definitely have other clinics in this space that really have like a telehealth startup mentality and kind of did some venture capital funding. And so they really have a goal, I think, of opening in all 50 states. And that was just never something that was really super appealing to me as like a small practice owner.
Yeah, getting licensing in each individual, it just sounds, you'd be spending your entire life filling out paperwork.
Yeah, no, thank you. So, I think I was really just like at a point where I was thinking like, well, that's not the way I want to grow. How do I want to grow? And I think there's just so much more ability to improve the lives of my community if I train like providers and healthcare organizations, right? Because as an individual provider, I can see a few hundred patients and change their lives. And that's an amazing experience. And I love it. And I will always continue to do that. But it's just a few hundred lives, and there are thousands and thousands and, millions of gender diverse people in the world. And I would like to have a bigger impact than that. So that's the goal.
Amazing stuff. Amazing stuff. And I can't wait to have you back on the show another time. As soon as you think of another topic that you want to discuss, let me know.
Sounds good.
Dr. Crystal Beal, thanks so much for coming back on the show.
Thanks, Bradley.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.